the House Commerce Committee to order. We do have a quorum present. May I have a motion to approve the minutes for February 8th, 2023? Representative Freiberg will move the approval of minutes for February 8th, 2023. Members, any discussion to that motion? Hearing none. Those in favor, please say aye.
Aye.
Any opposed? The motion prevails, and the minutes for February 8th, 2023 are approved. Members, the first bill on the agenda for today is House File 348. I will move that House File 348 be recommended to be re-referred to the Health, Finance, and Policy Committee. And Representative Howard, welcome back to the committee. Looks like you have a DE1 amendment.
Yes, Madam Chair.
Right.
I would present the bill in the shape I would like it in.
I will move the DE1-1 amendment. Representative Howard, would you like to describe that amendment, or does it simply get the bill in the shape that you would like?
It's just to get the bill in the shape that we
Very good.
would like it in.
Members, any discussion to the adoption of the DE1-1? All those in favor, please say aye. Aye. Any opposed? The motion prevails and the amendment is adopted. Representative Howard, to your bill as amended.
Chair, members, it's nice to be back in Commerce on the side of the table. On a bipartisan basis, over the past many years, this legislature has passed a series of new laws to help reduce the cost of prescription drugs. And this bill is a logical next step in our shared work to ensure that Minnesotans can afford the prescription drugs they need to survive and thrive. As many of you know, and as many of you worked and helped with, we passed a nation-leading bill, the Alex Smith Insulin Affordability Act, that is designed to prevent Minnesotans from losing their life because they can't afford their insulin. A version of this bill was part of Alex's bill that didn't get across the finish line, and it's long past time to take action. House File 348 would place a copay cap of $25 a month to help Minnesotans cover 3 chronic conditions: diabetes, asthma, and allergy conditions, all of which impact thousands of Minnesotans, all of which come with potential grave consequences if not treated properly, and all where medications and supplies to manage these conditions have skyrocketed. The high cost of insulin has been widely discussed by this legislature and continues to be a huge burden on Minnesotans. Asthma is a condition that impacts thousands of Minnesotans, and a recent study showed that the average asthma patient pays almost $2,000 per year in prescriptions. The bill also focuses on EpiPens, where we have seen skyrocketing prices as well. Importantly, this bill would also place a $50 monthly copay cap on medical supplies to manage these conditions. As you'll hear from testimony, there's families that are actually paying more for the medical supplies to manage their conditions than the prescription drugs, and these are having perverse outcomes. Patients are sometimes forced to choose inferior methods to manage their conditions simply based on cost. On this point, the ADA found that 15% of people with diabetes who rely on pumps or CGMs have delayed refilling needed supplies during the pandemic, and for 70% of them it was due to finances. And look, this should never happen. The cost and the terms of an insurance company should not dictate treatment. That should be between a doctor and a patient. And this bill will help provide peace of mind to families about the cost of those supplies and will lead to better health outcomes as well. It is worth noting that when Minnesota passed Alex Law, we were the first in the nation to do so, since many other states have done so or are seeking to do so. But this bill, copay cap, is an area where we're actually falling behind. It's an issue that has not been controversial. Over 20 states, red states in blue, from Washington, Oregon, Utah, Oklahoma, Texas, and the list goes on, has a similar legislation in place, and it's time we do as well. A couple final points before we hear from testifiers. Because we are lagging other states, we now have data from other states that support its value and discredit the claims we've heard about potential impacts. Following Colorado's legislation, they were the first state to move in this direction. A study reviewed documents from 21 health plans and found placing a copay cap on insulin either did not impact premiums or it was described as negligible. Members, for years, the insurance lobby has opposed this bill under the guise it will lead to significantly higher premiums and copays. They've never offered a shred of evidence to back that up, but now we actually have some good data. Due to bipartisan legislation authored by Senator Benson and Representative Elkins, Any cost-sharing changes must undergo a thorough actuarial analysis by the Department of Commerce, and this proposal went through that assessment. In total, the report found negligible long-term cost increases to overall premiums and copays if this bill becomes law. It found that the monthly cost for copays would go up 2 pennies per year if this bill, and the monthly cost of premiums would go up $1 per year if this bill was put in place. And additionally, the report showed many downstream savings because we will see better disease management if Minnesotans can afford their prescription drugs. An NIH study found the rate of hospitalization decreased when anti-diabetic drug adherence increased. And the same can be said with asthma medication, where an NIH study demonstrated that increased inhaler adherence could save hundreds of dollars in healthcare expenditures per child. And again, these statistics are about the savings to our health care system. That should only be a secondary reason we pass this bill. The most important is we know that Minnesotans are struggling and that this change would drastically improve both their bottom lines and their health. And it's really the ultimate no-brainer, and I look forward to hearing the discussion and testifiers that will do a better job myself of helping make the case for why we should move in this direction.
Thank you, Representative Howard. So we have 3 testifiers signed up. First is Carissa Kemp with the American Diabetes Association, followed by Adrian Thornton with Children's Minnesota, and Emily Hassenstab, also with Children's Minnesota. We have a number of testifiers and a number of bills on the agenda for today, so we are going to ask that folks keep their testimony to about 2 minutes if you can. Thank you so much. Introduce yourself and proceed with your testimony.
My name is Carissa Kemp. I'm the Director of State Government Affairs with the American Diabetes Association. Chair Stevenson and committee members, my name is Carissa, as I just said, my name is Carissa Kemp. Thank you for this opportunity. The American Diabetes Association published a Health Equity Bill of Rights, which envisions a future without unjust health disparities. The legislation before you takes steps to address 2 critical aspects of the ADA's Health Equity Bill of Rights. The first is the right to access insulin and other drugs affordably. People with diabetes account for 1 of every $4 spent in healthcare in our country, and growing numbers cannot afford the medications they need to survive. People with diabetes should not be able to, or should be able to get medication without having to choose between filling their prescriptions and other essentials. The second, and this bill also addresses this critical aspect, is the right to the latest medical advances. Medical technologies like continuous glucose monitors and insulin pumps, which would be impacted by House File 348, can be instrumental in treating and managing diabetes. Still, many people with diabetes do not have the same access to these life-saving technologies as do higher income peers. The latest advances in diabetes management should be accessible for all who stand to benefit. We also have evidence from other states, which Representative Howard spoke to, and also from the Commerce Department evaluation of the bill that shows this will have a minimal impact on premiums. At the same time, this legislation can improve health outcomes, reduce use of emergency rooms, lower the risk of developing complicated and devastating complications, all while ultimately lowering healthcare costs. Thank you again for the opportunity to speak in support of this important legislation, and I urge your support.
Thank you for your testimony. I'm not sure if our next 2 testifiers are testifying together or separately, but Adrian Thornton and Emily Hassenstab with Children's are up next. Thank you. You can introduce yourself and proceed with your testimony.
Thank you, Madam Chair and Committee. I am Adrian Thornton, and I am the Manager of Health Equity at Children's Minnesota. I'm very grateful to join Representative Howard in trying to get this bill passed. I started my career as a nurse and an infection preventionist, and I've worked at Children's Minnesota for over 20 years. The patients and families that we represent are vibrant and diverse, many of which are systematically disenfranchised. Almost half of our patient population is enrolled in medical assistance and live in socioeconomically depressed areas. Access to health care is not equitable in Minnesota, which leads to grave disparities in health outcomes, impacting our state's Indigenous, Black, Latino, and Asian communities most directly. This is clear when we look at health outcomes for the patients we treat for asthma and diabetes, my daughter being one of them. I have a very close friend whose daughter has type 1 diabetes. I have really vivid memories of sitting on the floor with her and crying because she was afraid that her daughter would not be able to live independently as an adult because of the cost of her medication. When the Alex Smith Insulin Affordability Act was passed, it provided incredible relief. My friend and her daughter were no longer forced to include the high cost of insulin in their monthly budget. My friend's daughter is independent and happily married today with a wonderful husband who helps her manage her diabetes. Unfortunately, due to the type of insurance she has, the copay for her insulin is in the hundreds of dollars. So they've had to opt to purchase their medications from Canada. The almost happy ending to this story is because of Minnesota's ongoing efforts to make insulin more affordable, but we have to go further. The provisions in this bill are needed because far too many families still cannot afford life-saving medications, leaving them with impossible choices. Thank you, Representative Howard, for your leadership on this bill. Thank you, committee.
Thank you for your testimony. Emily Hassenstab is next, and then I have Leah Greenside. Please introduce yourself for the record and proceed with your testimony.
Thank you, Madam Chair and committee members. My name is Emily Hassenstab. I am a nurse and diabetes educator at Children's Minnesota. I've also been living with type 1 diabetes for 18 years. This bill is near and dear to my heart, both professionally and personally, and I thank you for having me here today to express Children's Minnesota's support for House File 348. Children's Minnesota is the largest pediatric healthcare provider in the state. I have the privilege of working with patients and families in our diabetes center, where we serve over 2,400 patients. Our journey with these families often starts with one of their hardest days, the day they learn that their child has type 1 diabetes, a chronic disease with no cure. This is the day a child learns that they need to take medication and will be poked multiple times daily, every day, for the rest of their life. Families' lives are turned upside down by this diagnosis. On top of learning how to manage a chronic disease, they also now face the financial burden of purchasing the medication and supplies required to keep their child alive. I want to tell you about a patient I recently worked with. I'm going to call her Sophie. Sophie was a typically developing 3-year-old child who suddenly started losing weight and regressed in her potty training. Her mom, a single parent, addressed this quickly and brought her in for an evaluation. Sophie was diagnosed with type 1 diabetes, and our team got involved teaching her mom how to check Sophie's blood sugar and administer insulin injections, along with many other skills necessary to keep her alive. We sent prescriptions to their pharmacy, and Sophie's mom called us crying because their copay was over $1,600. None of these medications were optional, and over half of them need to be refilled every month. This is not an uncommon situation that we face, and it needs to change. Today, I ask you to empathize with this family and every family managing chronic disease. Try to imagine first the toll that a chronic disease diagnosis can have on a parent and their child, and then the unbelievable stress of knowing that the financial barriers to accessing the required life-saving medication and supplies, that it's next to impossible to overcome. This bill would not only provide relief to so many of the families that I work with, but it would also save lives by helping people access the required medications they need to survive. Thank you, Representative Howard, for your leadership.
Thank you for your testimony. Finally, Leah Greenside. Introduce yourself and proceed with your testimony.
Thank you, Madam Chair and members of the committee. My name is Leah Greenside. I live in St. Paul with my husband and 2 children. My daughter was diagnosed with type 1 diabetes 10 years ago when she was 7. We're small business owners, and we get our insurance through MNsure, and we've purchased plans through UCare for the last several years. In 2022, my family paid, we just did our taxes, we paid about $18,000 in medical expenses. This included over $13,000 in insurance premiums and $5,000 in out-of-pocket expenses. Diabetes medications and management tools accounted for about $4,000 of our total out-of-pocket medical expenses last year, or roughly 80%. So to break this down, we paid about $500 in total for my daughter's insulin and other diabetes medications, but that's only thanks to UCare's voluntary monthly cap on insulin costs. Otherwise, we would have paid thousands of dollars more, literally. We paid about $3,500 for my daughter's insulin pump and related supplies like infusion sets and continuous glucose monitors. I have an entire cabinet filled with stuff like this that I could show you. If this bill were law, my family would have saved about $3,000 in out-of-pocket medical expenses last year related to managing my daughter's type 1 diabetes. So those people who argue against this bill will claim that cost sharing is needed to put a downward pressure on the rising cost of healthcare. I can tell you the reality, though. As an individual consumer, I essentially have no power to lower my healthcare costs. And I'm going to tell you just a quick story from last year. Last year, I spent over a month trying to get the best price on a new insulin pump. This is the old one that's out of warranty that we can't use. Even with UCare's help, I was only able to find 2 in-network distributors, and it was impossible for me to learn how much the pump would cost before I actually bought it. Most maddening, I couldn't even buy the pump from the lowest cost that I found, which was directly from the manufacturer. The manufacturer's retail price for the pump was just over $5,000, but the retail price that UCare's preferred distributor, Fairview Pharmacy, quoted me was nearly $13,000, $8,000 more than the manufacturer's price. So I had to just buy the pump, not knowing what I was going to pay. 6 months later, in September, I got the bill. The negotiated price of the pump that UCare had was $7,600, which is better than the price that was quoted me, but still nearly $2,500 more than if I had bought it directly from the manufacturer. So in the end, we had met our deductible. We paid our 20% coinsurance, which was $1,500 for the pump. So in short, I found out that my insurance company's preferred in-network vendor was significantly more expensive than if I'd been able to purchase the pump directly from the manufacturer and cut out the middleman. So this cost both me and my insurance company money, which is passed on to all of us in our premiums.
Greenside, I'll just ask you to wrap up.
Yep.
Thank
I just want to say our system's broken and it's not a free market. Families like mine need your help to relieve the burden and cost of diabetes while we wait for broader health care reform. Thank you.
Thank you for sharing your story with us. 3 members of the public signed up to testify. First is Paige Ma, followed by Dan Andreessen and Peter Nelson. You can, Paige Ma, you're up first. Introduce yourself when you reach the table and proceed with your testimony. Thank you.
Good afternoon, Madam Chair and members of the committee. My name is Paige, and I am the mother of a child with multiple life-threatening food allergies to common foods such as dairy and peanuts. I am grateful to have this opportunity to give some brief personal remarks today. Our daughter was first diagnosed with allergies when she was only 9 months old, and this diagnosis turned our lives upside down. In addition to managing the purchase of allergy-friendly food substitutes, many of which are much more expensive, we also needed to purchase epinephrine, or EpiPens as they're commonly known, to always have with us, which we immediately did. Yet it wasn't until she was 2.5 that we discovered how severe her allergies actually are. She accidentally ate some food that she's allergic to, and then subsequently and rapidly developed problems with breathing, one of several steps in the reaction known as anaphylaxis, which is the most severe kind of allergic reaction. This required an immediate trip to the emergency room where she was given an EpiPen, followed by a 6-hour observation period to rule out a rebound reaction. Since that time, we now always carry an EpiPen 2-pack with us, have been properly trained, and have additional sets of EpiPens at school and in the nurse's office. Our child has suffered multiple anaphylactic reactions due to the severity of her allergies. The good news is that every time, her life was saved with epinephrine. At this point, Epi is the only treatment that will halt an anaphylactic reaction, and every allergy patient must carry a 2-pack at all times. But despite the good news about the effectiveness of epinephrine in halting an anaphylactic reaction, this leads us to a challenging situation for many allergy families. Most families with school-aged children need at least 2 sets, one to keep in the nurse's office at school and one to keep at home. If children participate in any other after-school activities, daycare, sports, etc., those areas may need independent sets as well. Sometimes there are additional caregivers, such as grandparents or other family members, who should also keep an EpiPen set at their house. This may require additional purchases. So a family may require 3 or 4 sets, but need at least 2. My daughter has had serious allergies for over 9 years. Our first copay years ago was around $60 per set. Last week, I refilled her EpiPen prescription, and our copay
Just
is
ask
now,
you to wrap up your comments. Thank you.
thank you, $125 per set. So in closing, I would urge the committee to help the thousands of allergy families in the state of Minnesota by helping them meet their children's basic needs of epinephrine prescriptions. These sky-high costs are not sustainable long-term for allergy families, and help is greatly needed. Thank you for your leadership and for this time today.
Thank you for sharing your experience. Next, we have Dan Andreessen with the Council of Health Plans, and then Peter Nelson. Introduce yourself and proceed with your testimony.
Madam Chair, members of the committee, my name is Dan Andreessen with the Minnesota Council of Health Plans. The council shares concerns raised regarding the cost of prescription drugs to manage these conditions. It's unconscionable what manufacturers of these drugs charge consumers, especially given how little it costs sometimes to manufacture these drugs. We understand the desire to limit what people pay out of pocket. All council members on the fully insured market have already lowered their prices for insulin to less than $25, and some are at $0. However, the decision before you is not without consequences. Unfortunately, passing this bill does not reduce the prices of these medications, and capping copays will mean costs will be shifted to premiums or cost sharing for others. Now, it is fair to say that some of these costs may not show up in premiums. If you're trying to set up a product that is maintaining those premiums, you may want to shift those to cost sharing. And for the individual market, this shift will have to result in an increase in cost sharing because of other federal regulations health plans have to follow. Health plans have many regulations that they must follow, and any new regulation has an interaction with that existing regulation. So you remember from my testimony a few weeks ago that products in the individual market must fall into one of 4 tiers, and each one of those tiers has a defined ratio of premium to cost sharing. For example, the bronze level plans all must have a 60% premium, 40% cost sharing ratio. Since this bill caps cost sharing for those drugs, cost sharing will need to go up for other services or medications in order for plans to meet that 40% threshold. Also, this bill will have interactions with other bills that have been moving this session. This committee a few weeks ago passed a bill to eliminate cost sharing for all secondary breast cancer tests. When you combine this bill with that bill before you today, there's going to be a cumulative impact when it comes to cost sharing shifting. And lastly, I just want to we often pass legislation in this at the Capitol and never go back to see what happened. If the committee and the legislature chooses to enact this legislation, one thing to throw out there is to require maybe a study of this mandate to look back to see what were the impacts of the passage, where health outcomes improved, and what were the financial impacts. Thank you.
Thank you, Mr. Andreessen. Peter Nelson. And then I will ask if there is anyone else in the public who wishes to testify on this bill before we proceed.
Hi, Madam Chair, members of the committee. My name is Peter Nelson. I'm a senior policy fellow at Center of the American Experiment, and I'm here to urge you to not micromanage health plan designs. In the health plan, for people with health plans, there is overuse of healthcare through health plans, and there's underuse of healthcare through health plans. That's a well-recognized issue within the healthcare research. And in this case, I appreciate what you're trying to tackle here and to tackle the issue of underuse. And I absolutely appreciate that, but health plans are challenged with balancing that underuse-overuse issue. And I think they are the best positioned to meet that challenge. And we've seen over the past few years how health plans have treated certain medications for diabetes and other chronic conditions. And the IRS recently actually issued a notice basically allowing high deductible health plans to offer preventive services at no cost for many of these conditions. So we all see this happening, and that's why I really don't think that this bill is necessary at this time, and also in the context of the fact that we're finally starting to see some prices come out through transparency efforts, which will hopefully shine a light on some of the issues that we're seeing here. And finally, I just want to also note one more issue with this bill, and that is the fact that it doesn't appear there's a non-neutral basis for selecting these 3 particular drugs. There's other people with chronic conditions that have issues as well, and as the last testifier basically just stated, by taking this action, you are necessarily increasing costs on other people, and so you have to weigh that yourself. And I think that health plans are in a better position to weigh those issues. So appreciate your time. Thank you.
Thank you, Mr. Nelson. Is there anyone in the public who wishes to testify on this bill? Seeing none, it looks like we do have an A1 amendment. Representative O'Driscoll, would you like to describe and move the A1?
Thank you, Madam Chair. Before I offer the A1 amendment, I do have just a quick question for the bill author.
Representative O'Driscoll, your mic is not working. Sure, wanna-
All right. Madam Chair?
That's much better. Thank you. Want to make sure your comments are on the record.
Thank you, I appreciate that. As I was saying, before I offer the A1 amendment, I do have a question for the bill author on the DE amendment, just to make sure that I've got some clarity on here. Representative Howard, on lines 1.9 to 1.11 on your DE amendment, the full sentence that begins on line 1.9, it says the cost-sharing limit for related medical supplies does not increase with the number of chronic diseases for which the enrollee is treated. Could you explain to me what the intent or what that means?
Representative Howard.
Madam Chair, Representative Driscoll, as we talked with nonpartisan, we included this line to capture if somebody, for example, has two of these chronic conditions. So let's say if you're someone that has diabetes and you have asthma. And so we're trying to, that's what the intent there is with that sentence.
Representative O'Driscoll.
Thank you, Madam Chair. So Representative Howard, if I were to be, my medical condition was such that I might have needed two or three of the combinations of things that are here, I would still be stopped out at $25 for all three, or up to three, and up to 50 on medical supplies per month. Is that what I'm hearing you say?
Representative Howard.
Madam Chair, Representative Driscoll, I might ask nonpartisan to be sure. We do have, it's 25 per month for each prescription drug. And then with the medical supplies, it would be topped out at that 50, I believe. But I might go to nonpartisan to make sure that my reading of that is correct.
We have Randy Chun. Will introduce yourself for the record and respond to the question. Thank
Madam
you.
Chair, Randy Chun with House Research. What Representative Howard is correct. The $25 is per prescription. So if you have 3 prescriptions over, say, 2 chronic conditions, that would be $75. The $50 is a total aggregate, no matter how many chronic conditions. So if you need medical supplies for 2 chronic conditions, you'd still be limited to $50 as the limit.
Thank you for that. Representative O'Driscoll.
Yeah, that helps me to be able to better understand and explain why I'm offering the A1 amendment today. As the bill has been amended with the DE, we basically are saying that if you have any one of these 3 conditions, there are medications that are out there right now in the marketplace. There are certain delivery systems or supplies that are available to help administer those different remedies or medications or prescriptions. And what the A1 amendment does is it says, in the enactment date of January 1st of 2024 with this bill, what we will do is we will say that any of those drugs and medical supplies that are currently available in the marketplace would be subject to the limits that were in the DE amendment. And why is that important, that we wouldn't necessarily go forward with prescriptions that may not have been approved until after that date? Because of the advances in medical technology, advances in medical medications, these other medications or prescriptions may be at a higher price point to the insurance company or to others for out-of-pocket expenses. And what it does is it could inadvertently build in cost escalators inside the insurance plan if we don't put some kind of a collar on here with a particular date going forward. We would have to revisit those particular prescriptions or those particular medications. And it just says we're going to lock in with what we currently have under the current law, and we wouldn't expand that for new medications under the current law because we just don't know what we're dealing with. And so I think it's a good amendment. It provides clarity. It gives folks what they're looking for, but also protects them on the downside where there could be, again, those additional medications or procedures that may cause the cost of insurance to escalate, and more people could find themselves without insurance or right back into the same situation without readdressing the situation at some point should those other medications or technologies occur. Thank you, Madam Chair, and I look forward to a yes vote by all members on this.
Thank you, Representative O'Driscoll. Representative Howard, any comments?
Madam Chairperson Driscoll, I understand the intent here. I would respectfully urge a no vote. One thing we're driving after here for Minnesotans is that peace of mind, that managing these incredibly complex, incredibly expensive conditions, that when they go to the pharmacy, they're going to have sort of a peace of mind about how much they're going to be paying for, whether it's the drugs that are currently available or new drugs. So I don't see a reason to exclude that. And I believe it's in the interest of Minnesotans that we establish that consistency. So I would urge a no vote.
Madam Chair?
Representative O'Driscoll.
Thank you. Representative Howard, I know that you have sat on this committee before, and last week we had the opportunity to hear a bill that talked about increasing and expanding Minnesota Care for all Minnesotans. Can you tell me, would Minnesota Care be covered under 62Q.481, which is the subject area of this bill?
Representative Howard.
Madam Chairperson O'Driscoll, the public programs like Minnesota Care would be included.
Representative O'Driscoll.
Well, thank you, Madam Chair. Once again, this just underscores why this amendment is so extremely important, because if we're going to be expanding this coverage, we're going to have a lot more folks who are using it, and it's going to put a plan that we learned last week that really it's the taxpayers who are backstopping Medicare, or excuse me, Minnesota Care right now, and we don't have an actuarial review of actually how much additional costs that would be to the state of Minnesota for expanding Minnesota Care. I think that this is just a very prudent thing to do, and again, it can be readdressed at some point in the future when we have more information and more data, but to go in unguarded like this could be very dangerous to all persons covered under health plans here in the state of Minnesota, including Minnesota Care. Again, I encourage folks to vote yes. Thank you, Madam Chair.
Thank you, Representative O'Driscoll. I have two members on the list. I'm not sure if those are to the amendment or to the bill as a whole. All right, Representative Cagle.
Thank you, Madam Chair. And I just think about my brother and his asthma, and if there was a drug that came out in, April of 2024 that better managed his asthma and put his life at less risk, I would want him to have access to that. So I also urge members to vote no.
Any further discussion to the A1 amendment, members? Seeing none, all those in favor, please say aye.
Aye.
Those opposed? No. The motion does not prevail and the amendment is not adopted. Now, members, any discussion or comments to the bill as a whole? Tina, excuse me. Chair Liebling.
Thank you, Madam Chair. So I just wanted to make one comment because, and thank you for your leadership on this always, Representative Howard. You've really been very dogged on this whole issue for pretty much as long as I've known you, I think, which is we really appreciate. I just wanted to make a comment about one of the testifiers was talking about how these out-of-pockets prevent over and underuse and about shifting the cost to other people in the insurance. And I have to say, in this context, I find that absolutely ludicrous. And the reason is that, listen to the testifiers. We're not talking about people who have the option not to use their diabetes medication or supplies. They've got to use it. And they're not going to use more of it because it's cheaper to them. They have to have what they have to stay healthy. And the same is true with the other medications. I mean, it's just ludicrous to think that there's any elasticity here. And some of the written letters from the same testifier, actually, is talking about, let's see. There's little evidence that high copayment costs are posing an obstacle to the appropriate use of the drugs in this bill. Really? I mean, you and I spent a year trying to negotiate the Alex Smith insulin program for that very reason, that people die. They literally die because they can't access these medications. So I just find that absolutely ludicrous. And the other thing I just want to mention briefly, the idea of shifting costs to other people. Well, when somebody gets really sick with diabetes because they don't have the appropriate medication, or their asthma's out of control, or they have anaphylactic shock and they need to be in the hospital for 3 days because they didn't get appropriate treatment immediately, those costs are also shifted. So what are we talking about here, folks? This is a really important bill, and thank you, Representative Howard.
Representative Dowd.
Thank you, Madam Chair and Representative Howard. Thanks for your work on this. I was able to work with you on that working group that we did a few years ago prior to the bill passing. Sometimes I think we talk about, and I appreciate Representative Liebling's mentioning that people can die. And I think sometimes we have a tendency to talk about the extremities of these issues in committee and on the floor. And people at home only hear what we say and they don't always know the background. And I don't think we should ever have this conversation without letting people know that if you can't afford your insulin, that you should call one of the manufacturers. They all have a program. They all actually did prior to us passing that bill that was as good or better than the bill that we passed. And they will make insulin available to you for free or almost nothing in every case. So please, if you're having trouble affording your insulin, reach out to them. And I want to applaud the work that they do. We shouldn't pit manufacturers against insurers or government against manufacturers. They did really great work, and they were actually earlier to this problem than we were. And they had actually already put in place programs to get people insulin for nothing in almost all cases. So I just want to mention that and make sure that people know if you're having trouble affording your insulin, there are programs available. No one should go without.
Representative Cleburne?
Thank you. The reason we're here today is because the current structure that we have is not working for families. I just want to tell the story of Joseph, a 16-year-old boy whose family was struggling. The father was a state worker, but had used up most of the money that they had already to care for Joseph's insulin. And the family had gone out for the day and had left Joseph home alone because he wasn't feeling great, because his activity structure was such that he really needed more insulin than his monthly supply provided for him, because not every child is the same. When they returned home from their outing that day, they discovered Joseph on the floor of the bathroom. Joseph had undergone shock, and Joseph was found with his incomplete organ failure. By the time they got young Joseph to the hospital, his organs were functioning at 40%. Young Joseph spent a week and a half in ICU, and then again 3 more weeks in the hospital thereafter. All of this pain and suffering could have been avoided if the family had access to the ability to get affordable and adequate insulin supply. Now, everybody talks to me about the sound of my voice, the raspiness of my voice, and it's because I use asthma inhalers. I use 3 every day for my own health condition. And when you cannot breathe, there's no, oh, let me go find a coupon. You can't breathe. And a trip to the emergency room is sometimes too long. I mean, we are talking about the very fundamental life-saving medications that keep people functioning. When you ration your inhalers, what happens is your brain doesn't function really well, you run out of energy, you just don't have the good quality of life. You may stay alive, but don't ask anyone to try to run across the street, even for something small. These medications are just fundamental to human life. Thank you.
Thank you, Representative Cleburne. Representative Howard, final comments?
Madam
I
Chair.
apologize, Representative O'Driscoll.
Yes, I was wondering if the bill author on the DE1 amendment could also explain lines 1.12 through 1.16. I've kind of read through that, and as it references the previous paragraph that I had talked about with the medical supplies, just wanting to know how this integrates with the federal code, Title 26 and 42.
Representative Howard.
I may ask Mr. Chund to come help me with this. I will say, related to the deductible issue, we do know that Minnesotans if you're on a high deductible plan, folks really hit the crunch earlier in the year, and that's partly why we want to make sure that this applies before the deductible. I'm just trying to remember if this is where we got at that, or if there was another interaction here that House Research can help me with.
Thank you. Mr. Chen?
So, Madam Chair, Randy Chen again with House Research. So what this is reacting, or what this language is, it's addressing some federal rules related to health savings accounts and catastrophic health plans. These are both high deductible health plans. And the federal rules basically say that, you need to count all of your costs toward the deductible. So what this is saying is that, that until the deductible is met, these provisions of the bill won't go into effect. So it's to comply with the existing, I guess, federal framework for these high deductible plans.
Representative O'Driscoll, follow-up?
Yes, please, and I won't belabor this, because it does talk about health savings accounts and the ineligibility. I thought I was with you until you said those deductibles have to be met first before the provisions in here of the 25 and 50 would kick in. Could you expand on that a little bit? Because then that seems like it doesn't do at all what Representative Howard's looking to try to accomplish, which is to put a outside cap on those outside of other deductibles and outside of other provisions in health policies.
Thank you, Representative O'Driscoll. It looks like Assistant Commissioner Peter Brickwitty is able to step in.
Madam Chair, for the record, Peter Brickwitty, Assistant Commissioner at the Commerce Department. Representative O'Driscoll, this language is in the bill, and actually similar language has been in other bills moving through the chamber. This deals with an unfortunate confluence of the policy goal of this bill and some federal tax law. So high deductible plans that feature a health savings account are required by federal tax law to have cost sharing in certain cases. And so this language would allow for those health plan designs to continue to exist, but keep them at the minimum level required to have that federal tax treatment and also then comply with this policy aim of this bill.
Representative O'Driscoll.
Well, thank you, Madam Chair. Then Mr. Brickwitty, this really doesn't accomplish what Representative Howard wants, is out of the chute $25 a month and $50 a month caps.
Mr. Brickwitty.
Madam Chair, Representative O'Driscoll, I would not agree with that statement. I think it affords the same policy goal to the extent that it can due to the tax treatment requirements under federal law. So I think it is applying the same principle to a set of plans that have a certain set of features required by the federal code, the federal tax code, which we obviously can't affect here in Minnesota. But I would not agree with that statement that it does not achieve the same policy effect. I wouldn't want to speak for the author, though.
Representative O'Driscoll.
I think I have my questions answered.
Thank you. Any further discussion to the bill as amended, members? Representative Howard, I'll give you final comments.
Thank you, members, and to all the testifiers as well. I'm just struck by the discussion and just this notion that we could somehow trust the pharmaceutical companies or trust the insurance companies or trust PBMs to be in this space advocating on what's best for Minnesotans, when I think all of us have heard story after story from Minnesotans asking us. They have dealt with these powerful interests, and I think that outcome has been clear. They're asking us to take up their mantle and to lean in to create a system that's a little more fair, that balances the scales a little bit. And I believe that's what this bill does. And in so many ways, we're helping provide a peace of mind for Minnesotans to afford their lives. We're actually going to help create healthier Minnesotans, as Representative Liebling mentioned. It really is a win-win. And I just have to say, I don't want to go all the way back to the debate on Alex Law, and I appreciate Representative Doubt's work on the working group on it, but to the public service announcement piece of it, one of the reasons we needed to pass that bill is because the pharmacy or the prescription drug plans that were sort of offered by the manufacturers weren't very accessible. But if you do need to access insulin, you can go to mninsulin.org and access insulin here in Minnesota because of that bipartisan law that we passed. And now this bill is the next step, and I would urge member support.
Thank you, Representative Howard. I will renew my motion that House File 348 as amended be recommended to be re-referred to the Health, Finance, and Policy Committee. All those in favor, please say aye. Aye. Any opposed, say nay.
No.
The motion prevails, and House File 348 as amended is recommended to be re-referred to the House Health, Finance, and Policy Committee.
Thank you.
Representative Howard.
Thanks, members.
Members, the next bill on our agenda today is House File 293. I will move that House File 293 be recommended to be re-referred to the Health, Finance, and Policy Committee. There is an A1-1. I will go ahead and move the A1-1 amendment. Representative Elkins, would you like to describe the A1-1?
Yes, Madam Chair. This amendment includes a couple of practical suggestions to improve the bill that I received from Peter Nelson, who will be testifying in the bill shortly. And it's just mostly practical improvements for the implementation of the bill.
Members, any discussion to the A1-1 to get the bill in the shape that the author would like? Seeing none, all in favor? Aye. Any opposed? The motion prevails and the amendment is adopted. Representative Elkins, to your bill as amended.
Yes, Madam Chair. So this is the first of 3 bills that's are all about healthcare pricing transparency. So the first one is a bill about medical pricing transparency. The second one, HF 294, is one that requires drug companies to reveal their prices and requires health plans to honor the drug coverage commitments that they made to their members when those members signed up for their plan. And HF 926, which among other things enables the Minnesota Department of Health to publish reports that compare the prices actually charged by healthcare practices to provide specific healthcare services. And if you remember this committee last year, then this is the return of House Files 57, 58, and 59 with significant improvements. They were heard as a collection last session as well, and each of them has been improved significantly since then. So 293 is the first. The age of consumer-driven health care began in 2004 with the passage of the Medicare Prescription Improvement and Modernization Act, which promoted the concept of the high-deductible health plan, which in combination with health savings accounts was intended to reduce the cost of health care by incentivizing healthcare consumers to take more control over their own health care decisions. The idea was that consumers would become better shoppers for health care if they had skin in the game. In theory, if consumers were required to pay a higher share of health care costs out of pocket, they would be more discerning about which health care procedures they requested and where they had them done. The concept took hold. Today, almost 2/3 of Americans with private health care coverage are enrolled in high-deductible health plans, and most public sector health plans and Medicare Advantage plans are also characterized by high deductibles. However, in practice, most of the cost reductions realized by these plans has come from foregone health care services, for both basic, preventative services and elective services, not from consumers selecting lower-cost options as was originally theorized by the plan designers. And the reason is simple. We, as health consumers, were never provided the information that we would need to shop for health care services based on both price and quality. In reaction, the Public Health Care Service Act, which was passed as part of the Affordable Care Act in 2010, included a new requirement that hospitals publish their prices to the public. After much litigation, the Centers for Medicare and Medicaid Services finally implemented a rulemaking which required all hospitals nationwide to publish their prices in a machine-readable format beginning in 2021 to enable third parties to assemble this price information into comparison reports for researchers and consumers. However, that rule did not specify any particular format for these machine-readable files, and so every hospital published its 2021 prices in a different format to thwart the objective. The files were created in literally hundreds of different formats, and every hospital in Minnesota used a different format. So in 2021, I introduced House File 57, which would have required all hospitals in Minnesota to publish their prices in a consistent format to facilitate price comparisons. In September of 2021, I responded to a CMS notice of proposed rulemaking to update their hospital pricing transparency rule by suggesting that CMS adopt the format that I had developed as a national standard. In response, I was asked by CMS to chair a technical expert panel that was convened last March to develop a recommended national standard for these files. This task force, which included representatives of 15 hospitals, including the Mayo Clinic and several rural hospital systems, and 15 organizations interested in compiling and using the data, including Turquoise Health, met between March and August of last year and succeeded in developing a recommended standard which CMS has now published as a best practice for all hospitals nationwide. House File 293, which is before us today, would require Minnesota hospital systems to reorganizing their existing files into this format by next January. Because the low-cost providers of these services tend to be services that can be planned in advance, like radiology scans, orthopedic joint replacement, vision enhancements, and the like, are not hospitals, but specialty practices such as Suburban Radiology, Twin Cities Orthopedics, or TRIA. The bill would require practices in these specialties with over $50 million in annual revenues to publish their prices in the same format by January 2025, so that their prices could be included in price comparison reports as well. So what would this look like in practice? And you can see the turquoise on the screen? Okay. Turquoise Health, great effort and expenses, compiled the available hospital prices nationwide and displays them in a user-friendly presentation at their website. So what you're seeing on the screen is what it looks like. So you enter the name of a procedure. Okay. What's going on here? Oh yeah, okay, so you can see them on the left. So it's $1,900 at St. Francis. You've got, these are all, am I getting only St. Francis? Let me just jump over to one that I'd shown. So this one is the price of that procedure at my hospital, Methodist Hospital. You can see the cash rate. You can see the rates by insurance plan. This is showing for Blue Cross right now. You can put in what is your remaining deductible, and it will show you exactly what the price is. Plus, if you scroll down for this hospital, they are also including, what is the quality measure for this hospital and how it's built up. So a shopper would be able to shop and see what, if they have an expensive procedure coming up, use this tool to look up the price at any hospital in the area and compare them, both the cash price and the prices by an insurance plan. So with information like this, the consumer for the first time would be able to make an informed decision about where to have their expensive healthcare procedures performed based on both price and quality. House File 293 charges the Minnesota Department of Health with developing or procuring a tool like this for Minnesota healthcare consumers. And the forthcoming fiscal note from MDH will reflect their cost of developing such a tool from scratch, but I think in the end they'll actually just slap their label on this one because it's really good. And that's good. First testifier.
Wonderful.
Is here.
You can introduce yourself and proceed with your testimony.
Madam Chair and Committee, thank you. I am Jean Abraham. I'm a health economist and professor in the School of Public Health at the University of Minnesota. So today, more than 90% of Minnesotans with employer-based coverage have an annual plan deductible. And among those who have that, the average family deductible is now more than $4,200 per year. We also know from research from the Rand Corporation and others that there's been rapid growth in commercial health plan prices, as well as significant geographic variation for equivalent medical services. These factors together strengthen consumers' incentives to search for and use pricing information when making choices about the providers from whom they seek care. Comprehensive, accessible, and timely pricing data are also important for supporting economic research to inform policymaking and regulatory activities to promote competitive healthcare markets. Many researchers, including myself, are investigating the implementation of the federal hospital price transparency regulation that went into effect in 2021. And as researchers seek to look at the important questions that these data can address, it has been very challenging in light of the format. The actual pricing data that exists on the hospital's websites, the machine-readable data, are very challenging to use in light of the lack of standardized data structure. and that's what HF 293 seeks to address. Specifically, by having standardized formats that will facilitate the merging of files together by researchers to support analyses of important state policy relevant questions. We'll be able to effectively monitor how prices are changing over time with different segments of privately insured populations in local geographic markets across Minnesota. We'll also be able to analyze the relationship between changes in prices and provider market competition, which is very important in light of increasing consolidation via mergers and acquisitions in both provider and insurance markets. And secondly, HF 293 confers value to consumers and employer purchasers by expanding the set of providers reporting data. This, of course, is a function of the fact that an increasing number of services can be delivered in ambulatory settings and providers' offices outside of the walls of the hospital. And it's important for consumers to be able to look across those care settings to get the most affordable and highest quality option. So HF 293 is an important step for helping consumers make more informed choices about their provider decisions, and it enables the policymaking and research communities to effectively monitor prices over time and the relationships between price changes and competition, which together are really important for ensuring affordable and accessible health care in Minnesota. Thank you.
Thank you, Ms. Abraham. Next, we have Peter Nelson. You could reintroduce yourself and proceed with your testimony.
Madam Chair, members of the committee, my name is Peter Nelson, and I'm a senior policy fellow with Center of the American Experiment, and I'm here in support of really all the bills today. And they're a great comprehensive package to address some serious failings in our healthcare system regarding price transparency. This bill in particular that we're talking about is focused on hospital prices. And in my previous role at CMS, I led efforts to draft the rule on health plan price transparency, which was coordinated with the hospital price transparency rule. And when I was drafting the health plan price transparency rule, this was really aimed at fixing some issues that states couldn't address because states couldn't address the self-insured space. This bill at the state level for hospitals is addressed at fixing, in part, an issue that we could not address at the federal level. We could not expand price transparency beyond the hospital setting. The statute did not give us that authority. So this is an important bill that expands price transparency beyond the hospital setting so that consumers can compare prices across all settings. And that's a key feature here. We've talked a lot about the standardization process in this bill, which is very important. When we were drafting these rules, we understood that these sorts of spreadsheets probably wouldn't be very useful to the general consumer. However, third-party developers would develop the tools that you're seeing today and to do this sort of thing and to help consumers when they're in their doctor's office make the right decisions for them. And that's a really key feature of this bill as well. And the other bills address some other shortcomings, which I, for time reasons, won't get into too deeply, but the price transparency efforts help move forward price transparency when some of those efforts have stalled at the federal level. There's still a very important state role for this to expand price transparency among prescription drugs. And then another bill relates to value-conscious purchase or value-based purchasing arrangements. And there's less known about those value-based purchasing arrangements, and this gives the state some tools to do some research into that by getting some more data. So thank you for your time.
Thank you, Mr. Nelson. Is there anyone in the public who wishes to testify on this bill? Seeing none, we will move to member discussion and questions. Members? Representative Niska.
Thank you, Madam Chair, and Representative Elkins. I was wondering if you could give us some insight on where the $50 million revenue threshold comes from and what exactly that means, and in particular whether that's going to continue to what's drawn into that and what's left out of that in the Minnesota market.
Representative Elkins.
Madam Chair, it's relatively arbitrary. The objective is to kind of phase this in with the other providers so that at first only the big guys with the resources to execute this would be drawn in. I expect what will happen is that The system vendors who provide practice management, electronic health record systems will develop this as a base capability for their clients, which would allow us to gradually extend it to smaller practices as well.
Representative Niska.
Thank you, Madam Chair and Representative Elkins. I appreciate that answer, and I was curious as to if you could give us a sense of how many providers in Minnesota would fall under that threshold and what over that threshold right now.
Yeah,
Representative Elkins.
Madam Chair, I think it's mostly going to get big practices like Suburban Radiology, TRIA, Twin Cities Orthopedics. The dental would come under this. I talked to the dentist, and they thought there might be 3 or 4 group dental plans that might, or practices that might come into it. So it would be comparatively small initially.
Any follow-up, Representative Niska?
Yes, thank you, Madam Chair and Representative Elkins. One of the letters raised the question of whether that means gross revenue or net revenue. That's
Yeah,
a little
it's-
bit undefined in the.
This
in
is
the-
gross revenue.
Representative Elkins.
Madam Chair, gross revenue. Mhm.
Thank you.
All right. Members, any further questions or discussion? Right. Seeing none, I renew my motion that House File 293 as amended be recommended to be re-referred to the Health, Finance, and Policy Committee. All those in favor, please say aye.
Aye.
Those opposed, say nay. The motion prevails. House File 293 as amended is recommended to be re-referred to the Health, Finance, and Policy Committee. Next up, we have House File 294 from Representative Elkins. I will move that House File 294 be recommended to be re-referred to the Judiciary, Finance, and Civil Law Committee. Representative Elkins, to your bill.
Thank you, Madam Chair. House File 294 has 2 parts. The first part requires drug manufacturers to provide their list prices to the Minnesota Department of Health for publication and to provide the MDH with 90 days' notice of their intent to increase the list price of a drug. Having provided the health plans and the pharmacy benefit managers with a measure of drug price predictability, the second part then requires the health plans and their PBMs to provide 30 days' notice to the Department of Commerce of their intention to change their drug formulas for their health plans in responses to changes in drug prices or the introduction of new drugs into the marketplace. In addition, and this is very important, health plan members would be grandfathered onto their current prescription drugs for the balance of the current plan year, allowing them to stay on drugs that are working for them until they have the opportunity to change their plan during the next open enrollment period. In all other areas of health insurance coverage, the plans are required by federal guaranteed insurability requirements to honor the term of the plan as they were described to prospective customers during plan open enrollment periods. Drug formularies are the only exception to this rule, and only because of the volatility of drug prices. I will leave it to the doctor seated to my right to explain why this is so important to give patients the option of staying on a drug that's working for them. The bill has been characterized or mischaracterized as a frozen formulary bill. It is not. Health plans may still change their formularies on 30 days' notice in response to price changes or the introduction of a new drug into the market. The PBMs now tell me that their primary bargaining leverage occurs when new, less expensive drugs are introduced into the market, providing an opportunity to switch patients from an expensive drug to a new, lower-cost alternative. However, the example they cite in the Milliman report that they commissioned exactly illustrates why this approach makes no sense. The example that they used was that in 2017, a new hepatitis drug called Mavret was introduced at a price of $26,400 per course of treatment, which was about 65% lower than the cost of treating hepatitis C with the existing drugs Harvoni and Epclusa. These hep C drugs are somewhat unique in that you take a 12-week course of one of these drugs and you're cured. Under this bill, the plan would be able to change its formulary to favor Mavret over Harvoni and Epclusa for future clients. What they would not be able to do is kick a patient off of Harvoni halfway through the course of treatment and make them start all over with Mavret. That would just make no sense at all. The Trade Association for the PBMs commissioned a study from Milliman Consulting, which indicated a full formulary freeze, which this is not, would result in a healthcare premium increase in the range of 0.2 to 0.4%. This bill was put through the healthcare mandate review process last session, which could not find any evidence of a significant increase in premiums as a result of the bill.
Thank you, Representative Elkins. Dr. Chasen, you can introduce yourself and proceed with your testimony.
Great. Thank you, Madam Chair and members of the committee. I'm Nicole Chasen, a family physician practicing in Minneapolis, and I'm here representing the Minnesota Academy of Family Physicians and the Minnesota Medical Association in strong support of House File 294. As a physician, my first goal is to work with my patients to determine what is needed to maintain their health and well-being. As a family physician who cares for patients across the lifespan, I have many patients who have chronic conditions where medical treatments can last for many years. Patients with rheumatoid arthritis, asthma, mental illness, and more. For these patients, it's critical that we find and maintain the right treatment so their condition does not worsen. There's nothing more infuriating than when I have a patient stabilized on a medication that is working for them, and then I hear the insurer or the pharmacy benefit manager is changing its formulary, forcing my patient to change from the medication that is working for them. Why should an insurer or pharmacy benefit manager be able to force my patient to change drugs when they decide to no longer cover that drug that has been working for them? My patient can't just choose to go to another health plan until the end of their enrollment year. For many conditions, changing from one drug to another is in the same class can work fine for them. But for certain conditions like mental illness, epilepsy, multiple sclerosis, and many more, changing medication mid-treatment can put a patient at severe risk for relapse. You will hear that these changes are done in the name of saving costs, but if a patient cannot get an inhaler, as we heard earlier, in a timely manner, and ends up in the emergency room, it ends up costing all of us much, much more. House File 294 does not prohibit pharmacy benefit managers from changing their formularies throughout the year. They can always add new drugs when they believe there is a benefit. They can add generics when they become available. They can also add new drugs that may be more cost-effective for patients. But what this bill would prohibit is forcing a patient to switch drugs once they've started a therapy that was originally covered by the plan, at least until the end of that patient's enrollment year. You also need to understand that the damage and cost these formulary changes are having on physicians and other prescribers. In most clinics today, there are administrative staff whose sole job is to spend their day on the phone with insurers and pharmacy benefit managers, appealing medical decisions made by someone other than that person who is treating the patient, trying to understand why that medication was changed, and trying to convince them that their decision was not in the best interest of that patient. While we are often successful in getting appeals, there are administrative costs and hassles being added to the process. And ultimately, care is delayed for the patient. I ask you to support House File 294. Thank you very much for your time.
Thank you, Dr. Chasen. We have a number of folks from the public who wish to testify on this bill. We are running short on time, and we still have another bill on the agenda for the day. So I would ask that folks keep their remarks to about 2 minutes. First up, I have Sharon Lamberton, followed by Michelle Mack, and then Joe Selwood. If you could introduce yourself and proceed with your testimony.
Good afternoon, Madam Chairwoman and members of the committee. My name is Sharon Lamberton. I'm a registered nurse by training, and I also work at PhRMA, the Pharmaceutical Research and Manufacturers of America, trade association of more than 31 drug companies. While we support many of these patient protections that you just heard well articulated, such as publishing the formulary so the patient can make an informed decision so they don't have to switch to a medicine that they've been previously stabilized on, and prohibiting mid-year changes, we have significant concerns about another portion of the bill, which is the transparency reporting requirements of WAC and AWP pricing metrics, because it does nothing to help the patient. These reporting and pricing metrics do not include significant negotiations and concessions that are made by the manufacturer to the plans and PBMs that reduce the price by almost 49%. So it doesn't reflect the true price, which is almost 50% lower. The manufacturers pay these rebates to get the drug with formulary placement that's favorable, and many patients are still experiencing formulary exclusions. 1,156 medicines were excluded just last year from formularies, and it happened to be cancer medications and oncology medications, and 50% of those medicines had no other generic or biosimilar alternative. In summary, 5 quick points on why we respectfully ask you to oppose this bill. Because the pricing metrics do not reflect the true price, as I mentioned, the state is already 12 months behind in the submission of the Prescription Drug Price Transparency Act, which passed in 2020. These additional transparency requirements of the bill are not subject to the same confidentiality requirements that the data being reported under that Transparency Act is subject to. Fourth, such pricing disclosures could harm and undermine the competitive environment of our marketplace. And finally, the prices for the medicines are set by plans and PBMs. The significant rebates that are paid by manufacturers should go to the patient at the point of sale so that they can benefit and afford their medications at the pharmacy counter. There's Milliman research to show support of that, where plan premiums only go up
Let's get a quick wrap
0.6%.
up.
Thank you for your time. I appreciate your time. Thank you.
Thank you so much. All right, next we have Michelle Mack, followed by Joe Selwood, and then Bentley Graves. You can introduce yourself and proceed with your testimony.
Good afternoon, Chair Corteza Bottoon, and members of the committee. My name is Michelle Mack, and I'm a Senior Director of State Affairs at the Pharmaceutical Care Management Association, also known as PCMA. I'm also a resident of Minnesota living in Carver County. PCMA is the National Trade Association representing America's Pharmacy Benefit Managers, or PBMs, which administer prescription drug plans for more than 275 million Americans with health coverage provided through employers, health insurance plans, labor unions, Medicaid, Medicare, federal employees, health benefit programs, and other public programs. Thank you for the opportunity to testify in House File 294. While we recognize and appreciate Representative Elkins' good intentions to create a balanced bill, we must respectfully oppose House File 294. We believe this bill will restrict our ability to utilize an important management tool and help keep drugs more affordable to patients and payers. We appreciate Representative Elkins' use of a non-severability clause in the bill, as it points to the ongoing challenges of addressing ever-increasing prescription drug costs in the context of formulary changes. However, there is still a cost. As Representative Elkins mentioned, the Milliman report shows that this type of policy will cost Minnesotans healthcare payers $75 million over 5 years. And the state's own analysis on this issue in prior use substantiates this. Whether this is referred to as an increase of 0.9% to 1.6% or $7 to $21.25 per member per month, we know for certain the bill will increase costs at a time when we're all trying to find better ways to lower patients' access to prescription drugs. Despite the best intentions, this bill moves us in the wrong direction. The core issue of this bill is in the requirement in Article 2, Subdivision 3, in which patients on a medicine may be subjected to a formulary change. A formulary change is made after a Pharmaceutical and Therapeutics Committee, or P&T Committee, has conducted a thorough and detailed clinical review of a new FDA-approved drug and makes a recommendation on whether the drug should be included in the plan's formulary.
Ms. Mack, I'll ask you to wrap up.
Okay.
Thank you.
I urge you to, we believe that House File 294 will raise prescription drug costs as it removes important total tools that PBMs use to deliver high-quality services to their clients and ultimately patients. Thank you for your time, and I will take any questions if you have them.
Thank you. We have Joe Selwood, followed by Bentley Graves, and finally Nick Zerwas. You can introduce yourself and proceed with your testimony, please.
Thank you, Madam Chair and members of the committee. My name is Joe Selwood, and I'm testifying on behalf of the Association for Accessible Medicines, the leading trade association for the manufacturers of generic and biosimilar medicines. There's a letter from AAM in your packet that outlines their opposition to House File 294. Through the use of generic and biosimilar medicines, Minnesota saved $5.3 billion in 2021. Generic drugs are 91% of drugs dispensed, but only 18% of the cost. And they make up only 2% of the overall healthcare spending. In the 2022 report, the CBO highlights the shift toward generic drugs has put considerable downward pressure on the average price of prescription drugs. And because of this, the U.S. Department of HHS prioritizes incentivizing and expanding generic and biosimilar uptake, calling generics a bright spot for the U.S. And while the federal government seeks to expand the use of generic and biosimilar medicines, House File 294 does the opposite. First, the bill does not allow formulary changes to include lower cost biosimilar medications. There will be dozens of biosimilars launching in the next few years, but this bill delays their entry into the Minnesota market. Delaying patient access means that patients will pay more. Second, the bill requires generic manufacturers report all drugs with a wholesale acquisition cost of $100 or more. Then, if a drug just reported is placed on a formulary in Minnesota, the generic manufacturer is required to provide notice for a price increase of just 1 penny. We already have the Prescription Drug Price Transparency Act, and requiring 2 additional layers of reporting does nothing to lower the price of drugs. Third, the bill requires the posting of the drug's wholesale acquisition cost and the average wholesale price. Neither the WAC or the AWP are what a patient pays, and this will create unnecessary confusion for Minnesota consumers. Because this bill includes generic manufacturers where it should not, and excludes biosimilars where they should be included, AAM opposes House File 294. Thank you, and I'm happy to answer any questions.
Thank you for your time. Bentley Graves, followed by Nick Zerwas. You can introduce yourself and proceed with your testimony.
Thank you, Madam Chair and members. My name is Bentley Graves. I'm with the Minnesota Chamber of Commerce, and I just want to start by thanking Representative Elkins for the work he's done across these 3 bills. There's much here to be supportive of when it comes to advancing the issue of transparency, both for payers and for patients. And we've been privileged to work with him on pieces of these bills. And again, there's much to support here. But I am here today to just put a pin in a piece of this bill that you've heard discussed by the other testifiers, so I won't belabor that point. But we do have past fiscal notes. We have a report from Milliman that was referenced. We have the mandate review report from last year, all of which suggests that there are cost considerations here. I know we're waiting for an updated fiscal note from this bill this year, as it puts both private payers and public payers on the same equal playing field when it comes to changing formularies. And so just want to, again, raise that issue, which has already been raised here today. Appreciate the many conversations we've had with Representative Elkins about this piece of the bill, but also other pieces of the bill, and look forward to keeping that work going in the stops ahead. But just appreciate the opportunity to offer that testimony today, and happy to answer any questions.
Thank you for your brief testimony, Mr. Graves. Finally, former Representative Nick Zerwas, please introduce yourself and proceed with your testimony.
Thank you, Madam Chair and members. Nick Zerwas with the Jacobson Law Group, representing today the American Health Insurance Plans. I won't belabor the point, as a lot of what we have to say is repetitive from previous testifiers, and you all have a letter from our organization in your packet. We applaud your desire to address healthcare costs for all Minnesotans, especially with respect to drug costs. It's imperative we work to corral rising healthcare spending by managing drug prices. We do, however, have concerns with some elements of this legislation, particularly those that limit the flexibility of formulary design. Prescription drugs represent the largest segment dollar for our healthcare spend, and the Center for Medicare and Medicaid Services project that spending for retail prescription drugs will be the fastest growing healthcare category. Given that background, AHIP is really concerned about any limitations placed on drug formularies, as it is a major tool for controlling costs for providers. And just a reminder that the way this works is employers in the state and everybody else works with health plans, works with pharmacy benefits managers with the goal stated to keep health costs low, to keep premiums affordable, to keep healthcare accessible for all people. The more tools you remove, the less able our insurers are to meet that goal on behalf of the insurers in the state of Minnesota and others that employ us. Thank you so much for your time.
Thank you, Mr. Zerwas. Is there anyone else in the public who wishes to testify on this bill today? All right, seeing none, we will move to member discussion and questions. Members, we do have the ability to go about 10 minutes over our meeting time today, but I would ask that we keep questions short and to the point if possible. First, we have Representative New.
Thank you, Madam Chair. I'm wondering if Ms. Lamberton would stand for a question.
Ms. Lamberton, you can come back to the desk. Go ahead, Representative New.
Thank you. I keyed in on a couple of things you were talking about in your testimony. You mentioned pricing metrics and a number of different players who are involved, the plans, PBMs, rebates, et cetera. So I'm wondering if you could suggest, maybe concisely, I don't know, how will this bill help patients at the pharmacy counter?
Thank you for that question, Chairwoman, and members. This bill will not help the patient at the pharmacy counter, and that is the point of my concern, because if we did have some of that rebate or even a little bit of that rebate go to the patient at the point of sale, they can afford their medicines. We have a Milliman study, separate Milliman study that I'm happy to share with you, that shows this has been done. And it saves patients on average $1,000 a year and will only increase premiums less than 0.6%. It's currently being done in West Virginia, and we almost have a full year of data that shows that. This is a real solution that will help the patients immediately afford their medicines. It's just completely unfair when the PBMs and plans get the medicine for a cheaper price, the reduced price, and the patients are paying full list price.
Representative New Brindley.
Thank you, Madam Chair. And thank you for that. So the other Milliman study is one that we have not seen yet. I don't think we have that.
I don't believe
We have
do.
one
I'll
of them
make sure
in
you
our
have-
packet.
Yes, and you should have the
Ms.
5
Lamberton.
solutions, which it touches on it, which is number 1, share the savings. And I will make sure and get that for you if you don't have it.
I'm going to go to Representative Elkins briefly.
Yeah, I asked that the Milliman study be included as a link. When we heard this one in Health, Finance, and Policy, we killed several forests worth of trees printing all this stuff out. So for this one, we just included the links, but there's a lot of links listed on the committee page for this, and the Milliman report is one of them, which I agree, it's a well-written report. You have to read it carefully. It talks about a full frozen formulary, and this is not anything close to a full frozen formulary.
Thank you for that clarification, Representative Elkins. Representative New Brindley.
Thank you, Madam Chair. And I just want to clarify, there's a couple of different Milliman reports. I'll look through those Milliman reports, but thank you for those comments. That was exactly my concern. My concern is that we're still not tackling the actual problem of what folks are paying. That is exactly my concern. Thank you, Madam Chair.
Representative Elkins.
Yeah. So first of all, so the consumers that will benefit from this bill will be the consumers who are on a drug, stabilized on this drug, doing well, and won't get kicked off of it. That being said, the other bill that she's suggesting, I'm also offering that bill. You should see that on today's bill introductions.
Thank you, Representative Elkins. Representative Niska.
Thank you, Madam Chair. And Representative Elkins, I wanted to zero in a little bit on the price stabilization provision at the top of page 7. And I just wanted to understand a little bit more the mechanics of how we, as the state of Minnesota, restrict manufacturers from increasing the wholesale acquisition cost of a drug. Can you help explain what the wholesale acquisition cost of the drug exactly is and how we as the state of Minnesota can restrict it from increasing?
Sure.
Representative Elkins.
Thank you, Madam Chair. We can't restrict it from increasing. What we can do under a California court decision is require that it be revealed. So the wholesale acquisition cost is the WAC, is kind of the list price of a drug, kind of the suggested price at which it might be sold to a wholesaler or some other direct intermediary. The AWP, the average wholesale cost, is kind of like the manufacturer's suggested retail price. It's usually the WAC plus a markup, and that would be the typical of the a reference price in which a wholesaler might sell it to a retailer. So to be clear, both the WAC and the AWP are reference prices. They would not be paid directly by a consumer. However, if the consumer is paying co-insurance payments, say for a very expensive drug like 25%, usually that's going to be tied to something that is in turn tied to one of those two, probably the AWP. So these two prices, they're reference prices for everything in this business, the discounts, the rebates, the co-insurance, everything is tied to these, and the purpose of calling them out in this bill is because the negotiations between the PBMs and the manufacturers are based on those prices as references. So we're trying to provide, this is something that the PBMs and the plan asked for, is that, look, if you're going to ask us to stabilize our formularies, we have to have at least some predictability in the prices of the drugs that we're purchasing. And the first article of this bill is intended to at least provide some predictability by, using these reference prices and at least requiring advance notification when a price is going to be increased. The other thing that it does, and I said 90 days on purpose, because every year in January, the drug companies increase all their prices. And by that time, it's done in January because the plans are in effect, the customers are locked into their plans. This would require those prices to be revealed in October when consumers are shopping from their health plans, and they could factor in a prospective price of that drug into what drug they plan to take and what plan they're going to choose based on the cost of that drug.
Representative Miska, a quick follow-up?
Yeah, thank you, Madam Chair, and Representative Elkins. I appreciate the answer. I am concerned that what we would be doing as the state of Minnesota is telling a drug manufacturer today that they can't change their price on transactions happening outside of Minnesota for the next 90 days.
Yeah, that is
even if they
absolutely
were-
not allowed. Yes.
Representative Elkins. Representative Niska.
Thank you, Madam Chair. And if I'm reading the severability clause correctly, if a drug manufacturer sues and gets this provision struck down on dormant commerce clause grounds, then the entire statute falls on as non-severable. Am I understanding that correctly?
Representative Elkins?
Madam Chair, that is correct. The deal is that we get some measure of stability, at least predictability in the drug prices, and in exchange, the PBMs stabilize their formularies.
Representative Niska? Is that?
Yeah.
Very good. Members, we do have one final member on the list. Representative New, I'm going to ask very quickly.
Just a quick question for you, actually, Madam Chair. I did look through on the committee page. This one, I think, was just accidentally placed on the committee page twice. So if maybe that could just be emailed out, the other report.
Certainly. Thank you for that.
Thank you.
All right. Representative Elkins, any final brief comments on the bill?
Very briefly, no, I mean, I've been working on this one for close to 4 years now, and, I think that I've struck the proper balance between protecting the patient's interest and minimizing the loss of leverage of the PBMs and the plans to negotiate prices with the manufacturers.
All right. Very good. With that, I will renew my motion that House File 294 be recommended to be referred to the Judiciary, Finance, and Civil Law Committee. All those in favor, please say aye. Aye. Those opposed say nay. The motion prevails, and House File 294 is recommended to be re-referred to the Judiciary, Finance, and Civil Law Committee. Members, we have one final bill on our agenda today, and we're going to try to get done.
Yep.
House File 926, Representative Elkins.
Thank you, Madam Chair. I think the motion we want to send this to Judiciary as well.
Very good. I will move that House File 296 be recommended to be re-referred to the Judiciary, Finance, and Civil Law Committee. And I will move the A3 amendment. Would you like to describe the A3?
Yes, the A3 amendment is a clarification that was requested by Representative New and during the Health, Finance, and Policy Committee meeting.
Right.
So it clarifies that the reporting of prices is by practice, not by individual practitioner.
Thank you. Any discussion to the A3 amendment, members? Seeing none, all in favor, please say aye.
Aye.
Aye. Any opposed? The motion prevails and the amendment is adopted. Representative Elkins, we'll move to your bill as amended, and it looks like you have one testifier, Dr. Chazen.
Yes, and she can join me here while I'm
Wonderful.
reading it. So the
Thank you.
All-Payer Claims Database is a repository of de-identified healthcare claims data submitted by the state's health plans and administered by the Minnesota Department of Health. It is a healthcare policy analysis database used by the Minnesota Department of Health to study healthcare costs and outcomes. Minnesota is one of 17 states which have all-payer claims databases for public policy analysis. This bill would eliminate the current July 1st, 2023 sunset date on the use of the all-payer claims database. It would require health plans to include data related to value-based incentive payments to providers in their submissions. It would include dental information for the first time. It would allow the Minnesota Department of Health to publish comparative price information for healthcare procedures across healthcare practices, but not by individual practitioners. I would note that Florida uses the all-payer claim database for its primary means of reporting prices to consumers. And it would require ERISA plan administrators to ask their employer plan sponsors if they want their claims data of their employee plan members to be included in the APCD, because under federal law, the ERISA plan participation is voluntary. But I would add that the Minnesota Chamber and the Minnesota Business Partnership encourage their members to participate because of the value that this provides. And it would require all plans to submit their claims data monthly to make the data more timely. Most plans already submit their data monthly. It's actually easier, but the current law only requires semi-annual reporting.
All right, Dr. Chazen, reintroduce yourself, please.
Sure. Thank you again, Madam Chair and members of the committee. Again, my name is Nicole Chasen. I'm a family physician practicing in Minneapolis, and I'm testifying in strong support of House File 926 on behalf of the Minnesota Academy of Family Physicians. We are the largest physician specialty organization in Minnesota with more than 3,100 family physician, resident physician, and medical student members across the state. House File 926 is needed to update the all-payer claims database to ensure that it collects a complete picture of how healthcare is paid for in Minnesota. Currently, the APCD only collects payments that are found in an insurance claim. It is missing a large portion of payments, including value-based payments, infrastructure costs, care coordination, and other patient support services. Minnesota's APCD has been an invaluable tool since 2008 to analyze variations in healthcare costs and quality, study hospital readmissions and trends for specific chronic conditions, and more. As we work to ensure that all Minnesotans have access to high-quality, affordable health care, both national and international data shows that a greater investment in primary care and prevention results in better care and lower costs. However, before Minnesota can move forward with that, we need a clearer, more comprehensive picture of healthcare spending in our state. We need to capture all the ways that we're paying for healthcare to understand how to make our healthcare system work and work best for the people it serves, and to ensure that we are getting value for our healthcare spending. Without this data, how do we, policymakers, healthcare team members, and patients, set a vision for a system that works for all Minnesotans? House File 926 also directs the Commissioner to use the updated APCD data to report to the legislature the volume and distribution of healthcare spending with a particular focus on value-based care models and primary care spending. Family physicians and other primary care providers are critical as we embrace a value-based delivery and payment model that recognizes the importance of prevention, addressing health disparities, and keeping people healthy. Data from the Primary Care Collaborative and the Milbank Foundation show that investing more in primary care lowers healthcare costs, results in higher patient satisfaction, and leads to fewer hospitalizations and emergency department visits. Yet, according to a recent MDH study of claims-only data, that shows only 6% of healthcare spending goes to primary care in Minnesota. Again, we need a more complete picture of healthcare spending in our state to truly understand needs and gaps. House File 926 is critical to you as policymakers to know how healthcare is currently paid for in Minnesota and to help inform any next steps in making our healthcare payment system work best for the people of Minnesota. Thank you for your time.
Thank you, Dr. Chazen. Unfortunately, we are out of time, members, for public comment on the bill. If anybody in the public wishes to submit testimony, they can do so written. We'll make sure that the committee members receive that. Members, any discussion or questions to the bill as amended? All right. Representative Elkins, I'll give you final comment.
Nope, this one is it's a kind of a clean omnibus cleanup bill. It would dramatically improve the quality and the timeliness of the data in this very useful database, and urge you to vote yes.
Then I will renew my motion that House File 926 as amended be recommended to be re-referred to the Judiciary, Finance, and Civil Law Committee. All those in favor, please say aye.
Aye.
Aye. Those opposed, say nay.
No.
The motion prevails, and House File 926, as amended, is recommended to be re-referred to the Judiciary, Finance, and Civil Law Committee. Members, we've concluded our agenda just 5 minutes over today. Thank you so much for your time.
I'm going to keep mine for now.